Okay, I'm going to do part of 2/28/2020 Friday's Final Frontier NPTE reading. I might do 2 videos on this because I probably won't finish it all tonight. So let's go ahead and start the reading. First from this book here. Therapeutic Exercise Foundations and Techniques. And so let's go ahead and put that over here. And we'll start the reading over here. Make this a little bit bigger. There we go.
Fibromyalgia and myofascial pain syndrome. Fibromyalgia, FM, and myofascial pain syndrome, MPS, are chronic pain syndromes that are often confused and interchanged. Each has a distinct proposed etiology. Individuals with FM process nociceptive signals differently from individuals without FM, and individuals with MPS have localized changes in the muscle. Although there are some similarities, the differences are significant and determine the method of treatment. They are summarized in Table 11.2.
Okay, so we're going to pause it there and look at 11.2, Table 11.2, which looks like similarities and differences between fibromyalgia and myofascial pain syndrome. The similarities: pain in muscles, decreased range of motion, postural stresses. What are the differences? Fibromyalgia, tender points at specific sites, no referred patterns of pain, no tight band of muscle, fatigue and waking unrefreshed. Myofascial pain syndrome, trigger points in muscle, and those are the trigger points right there. We'll go with that in a second. So you have trigger points in the muscle versus tender points at specific sites. You have referred patterns of pain versus no referred patterns of pain. You have tight bands of muscle versus no tight bands of muscle. And then you have no related fatigue complaints. And with fibromyalgia, you have fatigue and waking unrefreshed. Okay, so let's go back to the reading here. And I think I'm actually going to zoom this up. There we go.
Fibromyalgia, FM, as defined by the American College of Rheumatology in 1990, is a chronic condition characterized by widespread pain that affects multiple body regions, right or left side, upper or lower half of the person, plus the axial skeleton, and that has lasted for more than 3 months. Additional symptoms include 11 of 18 tender points at specific sites throughout the body, figure 11.7.
Okay, so let's look at figure 11.7. So in the front of the neck here, in the back of the neck, upper trap, levator scapulae areas, suboccipital muscles, elbows, inside of the knee, medial knee, above the joint line, around probably the medial condyle, lateral hip, and then lumbar SI region right here. Fibromyalgia, tender points. Figure 11A, composite pattern of pain referred from tender points in the right piriformis muscle. TRP1 here indicates the most common TRP location, trigger point. The red stippling locates a spillover part of the pattern that may be felt as less intense pain than that of the essential pattern, solid red. So the red stippling locates this here and here. The spillover part of the pattern that may be felt as less intense pain than that of the essential pattern, which is the positive red part here. The spillover pain may be absent, and so that's the myofascial pain and dysfunction. So we've got referred pain, no referred pain. Fibromyalgia, no referred patterns. Myofascial pain syndrome, referred patterns. Myofascial pain syndrome, trigger points. Fibromyalgia, trigger points at specific sites.
Non-restorative sleep and morning stiffness. A final common problem is fatigue with subsequent diminished exercise tolerance. Prevalence of FM, it is estimated that 2% of the population to the power of nearly 5 million adults 18 years old or older to the power of have FM, with women affected far more than men, 3.4% to 0.5%. In addition, the prevalence increases with age, with 7.4% of women ages 70 to 79 affected. While women have also been shown to have greater pain intensity, men report a longer duration of symptoms of FM, 1 of 12. Characteristics of FM. The characteristics of FM include the following. The first symptoms of FM can occur at any age but usually appear during early to middle adulthood for many of those diagnosed. The symptoms develop after physical trauma such as a motor vehicle accident or a viral infection, although the symptoms vary from individual to individual. There are several hallmark complaints. Pain is usually described as muscular in origin and is predominantly reported in the scapula, head, neck, chest, and low back. Another common report is a significant fluctuation in symptoms. Some days an individual may be pain-free, whereas other days the pain is markedly increased. Most individuals report that when they are in a cycle in which the symptoms are diminished, they try to do as much as possible. This is usually followed by several days of worsening symptoms and an inability to carry out their normal daily activities. This is often the response to exercise. Individuals with FM have a higher incidence of tendinitis, headaches, irritable bowel, temporal mandibular joint dysfunction, restless leg syndrome, mitral valve prolapse, anxiety, depression, and memory problems. Factors contributing to a flare. Although FM is a non-inflammatory, non-degenerative, non-progressive disorder, several factors may affect the severity of symptoms. These factors include environmental stresses, physical stresses, and emotional stresses. FM is not caused by these various stresses, but it is aggravated by them. Environmental stresses include weather changes, especially significant changes in barometric pressure, cold, dampness, fog, and rain. Physical stresses include repetitive activities, such as typing, playing piano, vacuuming, prolonged periods of sitting and or standing, and working rotating shifts. Emotional stresses or any normal life stresses, 2 of 12. Principles of management. FM. Individuals with FM typically have lower tolerance for activities and exercise. People often report to the power of and bad to the power of days in which they have more or less energy, respectively. Learning to pace activities throughout the day so as to not push too hard or too little is an important component of the intervention plan exercise. Research supports the use of exercise, particularly aerobic exercise, to reduce the most common symptoms associated with FM. Additional interventions: prescription medication, over-the-counter medication, instruction, and pacing activities. In an attempt to avoid fluctuations in symptoms, cognitive behavior therapy, avoidance of stress factors, decreasing alcohol and caffeine consumption, diet modification, manual therapy, 3 of 12. Myofascial pain syndrome. Myofascial pain syndrome, MPS, is defined as a chronic, regional pain syndrome. The hallmark classification of MPS comprises the myofascial trigger points, MTRPS, in a muscle that have a specific referred pattern of pain, Fig 11.8, along with sensory, motor, and autonomic symptoms. The trigger point is defined as a hyperirritable area in a tight band of muscle. The pain from these points is described as dull, aching, and deep. Possible causes of trigger points. Although the etiology of trigger points is not completely understood, some potential causes are chronic overload of the muscle that occurs with repetitive activities or that maintain the muscle in a shortened position, acute overload of muscle, such as slipping and catching oneself, picking up an object that has an unexpected weight, or following trauma such as in a motor vehicle accident. Poorly conditioned muscles compared to muscles that are exercised on a regular basis. Postural stresses such as sitting for prolonged periods of time, especially if the workstation is not ergonomically correct, and leg length differences. Poor body mechanics with lifting and other activities. Principles of management. Myofascial pain syndrome. Pain from trigger points is described as dull, aching, and deep. Additional impairments from the trigger points include decreased ROM when the muscle is being stretched, decreased strength in the muscle, and increased pain with muscle stretching. The trigger points may be active, producing a classic pain pattern, or latent, asymptomatic unless palpated, 4 of 12. Treatment consists of 3 main components: correct chronic overload, correct contributing factors that cause chronic overload of the muscle, such as faulty posture, repetitive activity, or poor lifting techniques. The correction is often done with education, including stressing the importance of taking intermittent mini breaks. If indicated, an ergonomic assessment of the work environment is performed to eliminate the trigger point. Several techniques are used to eliminate trigger points: contract, relax, passive stretch, done repeatedly until the muscle lengthens, contract, relax. Active stretch, also done in repetition. Trigger point release spray and stretch modalities: dry needling or injection, strengthen muscle. Exercise prescription, using a muscle endurance protocol, is typically indicated for core and scapular stabilizing muscle groups to improve overall muscle performance, 5 of 12. Focus on evidence. In 2010, Wolf and Associates developed preliminary diagnostic criteria to complement the ACR-specific criteria, including the measurement of symptom severity. The authors recommend the following: Widespread Pain Index, WPI, 7, and Symptom Severity, SS, Scale 5, or WPI 3 to 6 and SS 9. These criteria correctly classified 88.1% of individuals with FM determined from the ACR classification without tender point palpation. The SS scale includes items such as somatic symptoms, not feeling refreshed after sleeping, fatigue, and cognition. Clinical tip: the Fibromyalgia Impact Questionnaire, FIC, originally developed in 1991, includes 10 items that assess the patient's overall function status. A higher score is correlated with lower function. It has been used in many studies to report progress and predict successful outcomes. The FIC has been modified in 1997, 2002, and 2009 and has been shown to be valid and reliable. The minimal clinically important difference has been estimated to be 14%, 6 of 12. Focus on evidence. The CPGs for aerobic fitness exercises in the management of fibromyalgia, Part 121, and the CPGs for strengthening exercises in the management of fibromyalgia, Part 222 show emerging evidence that aerobic fitness and strengthening exercises are beneficial in the overall management of FM for pain relief, muscle strength, quality of life, self-efficacy, and decreased depression, and that progressive strengthening programs do not cause an exacerbation of exercise-induced FM symptoms. The guidelines also recommend individualized programs with multiple treatment regimens be used due to the variability in FM symptoms. An updated evidence report from the Cochrane Collaborative summarized the findings of 5 randomized trials related to FM and exercise. The reviewers concluded that while moderate intensity and moderate to high intensity resistance training can improve function, pain, strength, and tenderness in people with FM, an 8-week aerobic program has even better outcomes. Furthermore, the authors reported that a 12-week low-intensity exercise program was superior to flexibility training for improving pain and function. While these findings are supported elsewhere in the literature, some evidence suggests aerobic activity is sufficient. In a randomized controlled trial, participants with FM tracked their daily steps. It was determined that people averaging at least 5,000 steps each day had better functional outcomes after 12 weeks as compared with those individuals with less than 5,000 steps a day. Still, other research promotes a combination of strength and flexibility training for improved functional outcomes and decreased pain. Clinical tip: when beginning any type of exercise with individuals with FM, it is best to begin at lower levels than recommended by the American College of Sports Medicine for aerobic and strengthening, and to slowly increase the activity. If the exercise leads to an increase in FM symptoms, reduce the intensity, while encouraging continued participation in the exercise. 7 of 12. Focus on evidence. Recently, researchers have looked at the contribution of MTRPS as a contributing factor in chronic headaches, tension-type headaches, mechanical neck pain, and shoulder disorders. Additionally, Iglesias Gonzalez and Associates 74 compared active and latent trigger points, LTRPS, in participants with nonspecific low back pain. The authors reported direct correlation with increased number of trigger points and high pain intensity, p. 0.001, and worse quality of sleep, p equals 0.03. Lucas and Associates investigated the muscle activation pattern, MAP, of scapular muscles during arm elevation in pain-free individuals without trigger points and pain-free individuals with LTRPS. The LTRP group had a significant difference in MAP, p. 0.05. These individuals were then treated with either a placebo or active intervention to deactivate the trigger point, and the MAP was reassessed. There was a significant difference, p. 0.05, in MAP after deactivation of the LTRPS. Focus on evidence. Dry needling, DN, has been shown to be a low-risk intervention that can decrease pain severity and pain pressure threshold, as well as improve functional outcomes in people with MTRPS. In a recent randomized controlled trial, Zaifer and Associates found that DN significantly decreased pain intensity when compared with trigger point compression technique of the upper trapezius. Additionally, a meta-analysis showed both intermediate and 4-week follow-up improvement in pain in the cervicothoracic region when using DN as the intervention. Clinical tip: if the cause of the trigger point in myofascial pain syndrome is a chronic overload of the muscle, eliminate the contributing factor prior to addressing the trigger point. Initiate muscle strengthening when ROM is restored and the trigger point has been addressed. 8 of 12.
So that's just a little bit on myofascial pain and fibromyalgia. Not real in depth, kind of superficial. The next topic on today's reading is examination of sensory function. So let's see the PowerPoint. That is, the reading is taken from the Physical Rehabilitation 7th edition, Chapter 3, examination of sensory function. It's the same in the 6th edition as it is the 7th edition. So let's go ahead and listen to the reading on that.
Pathways for transmission of somatic sensory signals. Somatic sensory information enters the spinal cord through the dorsal roots. Sensory signals are then carried to higher centers via ascending pathways from one of two systems, the anterolateral spinothalamic system or the dorsal column to the power of medial lemniscal system. Anterolateral spinothalamic pathway. The spinothalamic tracts are diffuse pathways concerned with non-discriminative sensations such as pain, temperature, tickle, itch, and sexual sensations. This system is activated primarily by mechanoreceptors, thermoreceptors, and nociceptors and is composed of afferent fibers that are small diameter and slowly conducting. Sensory signals transmitted by this system do not require discrete localization of signal source or precise gradations in intensity. After originating in the dorsal roots, the fibers of the spinothalamic pathway immediately cross and ascend up the spinal cord through the medulla, pons, and midbrain to the ventroposterolateral (VPL) nucleus of the thalamus. Figure 3.4. Axons of the VPL neurons project to the somatosensory cortex via the internal capsule. Compared with the dorsal column to the power of medial lemniscal system, the anterolateral spinothalamic pathways make up a cruder, more primitive system. The spinothalamic tracts are capable of transmitting a wide variety of sensory modalities. However, their diffuse pattern of termination results in only crude abilities to localize the source of a stimulus on the body surface and in poor intensity discrimination. 9 of 12. The three major tracts of the spinothalamic system are the 1. Anterior, ventral, spinothalamic tract, which carries the sensations of crudely localized, light touch and pressure. 2. The lateral spinothalamic tract, which carries pain and temperature. And 3. The spinoarticular tract, which is involved with pain sensations, especially diffuse, deep, and chronic pain. Dorsal column to the power of medial lemniscal pathway. This system is responsible for the transmission of discriminative sensations received from specialized mechanoreceptors. Sensory modalities that require fine gradations of intensity and precise localization on the body surface are mediated by the system. Sensations transmitted by the dorsal column to the power of medial lemniscal pathway include discriminative touch, stereognosis, tactile pressure, barognosis, graphesthesia, recognition of texture, kinesthesia, two-point discrimination, proprioception, and vibration. This system is composed of large, myelinated, rapidly conducting fibers. After entering the dorsal column, the fibers ascend to the medulla and synapse with the dorsal column nuclei gracilis and cuneatus. From here they cross to the opposite side and pass up to the thalamus through bilateral pathways called the medial lemnisci. Each medial lemniscus terminates in the ventral posterolateral thalamus. From the thalamus, third-order neurons project to the somatic sensory cortex. Projection to sensory association areas in the cortex allows for the perception and interpretation of the combined cortical sensations. Figure 3.5. Table 3.2 presents a comparison of the most salient features of each ascending pathway. 10 of 12.
Okay, I'm going to make a separate video about the information that we just listened to the reading on, so stay tuned for that. But that was the reading. And then the third part of today's reading is on assessment of pain from the Principles and Techniques of Patient Care book. So let's go ahead and listen to that reading.
Assessment of pain in many hospital environments. Patient pain is considered the fifth vital sign. Some facilities have created comprehensive pain clinics or pain management teams. especially facilities that treat cancer patients or have a large population of orthopedic or neurologic patients. Pain management medical teams typically include some or all of the following individuals: a clergy member, a dentist oral surgeon, a dietitian, an internist, a neurologist neurosurgeon, a nurse, an occupational therapist, an oncologist, an orthopedist, a pharmacist, a physiatrist, a physical therapist, a radiologist, and a vocational counselor social worker. Goals for an interdisciplinary pain team or for an individual clinician are to eliminate the source of pain when feasible, teach the patient to function within pain limitations, improve pain control through conservative physical and psychologic methods, relieve drug dependency, treat underlying depression and improve psychologic well-being, address areas of secondary gain, improve family and community support systems, provide access to occupational rehabilitation, provide patient education on pain, anatomy, physiology, posture, body mechanics, and medications, improve strength, flexibility, and general physical conditioning, and maximize the patient's functional level. In the initial assessment of pain, the clinician should document the onset and temporal pattern of pain. Ask the patient to point to the exact location of pain on his or her body, on the clinician, or on a pain questionnaire, if available. Figures 311 through 313 and tables 39 and 310. Determine whether the pain radiates or spreads to other parts of the body. Ask the patient to describe the pain, because words can provide valuable clues to the cause. For example, patients who describe their pain as burning or tingling are likely to have a neuropathic cause of pain, particularly if associated with subjective numbness, loss of sensation, and weakness. An assessment of pain intensity should include an evaluation of the present pain intensity and when the pain is at its least and worst. Knowing factors that aggravate or relieve the pain helps clinicians design a better plan of care. 11 of 12. The patient should describe the symptoms at onset, whether they are constant or intermittent, and which activities make the symptoms worse or better. For example, bending, sitting, rising, standing, walking, or lying. Ask the patient if the symptoms are worse upon awakening, as the day progresses, or in the evening. Document whether the pain increases during a cough, sneeze, or strain and if bladder function is affected. The initial pain assessment should elicit information about changes in activities of daily living, including recreational and work activities, sleep patterns, sleeping postures and sleep surfaces, mobility, appetite, and mood. Procedure 3-7. If the patient is cognitively impaired, the inability to communicate information concerning pain places them at high risk for insufficient pain control. 2 common risk groups in palliative care include patients with underlying brain pathology such as dementia, stroke, Parkinson's disease, or developmental abnormalities, and patients receiving sedating medications, such as intensive care unit patients who are given sedative hypnotics to control the anxiety and agitation that can accompany mechanical ventilation. Assessing the pain of a cognitively impaired patient includes asking the patient, as some useful information may be attained, interviewing the family or caregivers for patient behaviors that may indicate pain, such as the patient placing a hand on his or her forehead to indicate a headache, restlessness, or loss of appetite, reviewing the medical record for known pain, inducing conditions such as a painful diabetic neuropathy or fracture that was present before the patient became cognitively impaired, and completing a physical assessment and checking the medical record for laboratory values that may indicate pain, for example, a urinary tract infection. In addition, caregivers should use a validated pain rating system for cognitively impaired persons. Such rating systems focus on the following observational items: facial expression, body posture, vocalizations, interactivity, and appetite. Table 311 can be used as a reference tool for nonverbal pain indicators that may be helpful in assessing pain in cognitively impaired persons, nonverbal patients, and patients with a language barrier. Other tools for pain assessment can be found in the bibliography. 12 of 12.
Okay, so that is all of the reading for this day. So let's go back to the slideshow. 22820 Friday, sensory spinal pathways and pain terminology, fibromyalgia and myofascial pain syndrome, and the pain scale for adults and children. 3 different books. So out of this book, we did the similarities and differences between fibromyalgia and myofascial pain. We already went over this table. We already went over these 2. In the physical rehab book, examination of sensory function, chapter 3, the table 3.2, features of pathways for transmission of somatic sensory signals. The anterolateral spinal thalamic pathway, non-discriminative, pain and temperature, broad spectrum of sensory modalities, crude localization, poor intensity discrimination, poor spatial orientation relative to the origin of stimulus. So that is the type of sensation. Afferent fibers are small in diameter and slow in conducting. Slow diameter, slow conducting. Skin, the origin is skin. Mechanoreceptors, thermoreceptors, and nociceptors. Mechanoreceptors, thermoreceptors because we're looking at temperature. Nociceptors because we're looking at pain. Okay. The projection is from the dorsal roots of the spinal nerves. Synapse at dorsal horns. Fibers cross and move up the spinal cord through the medulla, the pons, and membrane to the cut that off. Posterolateral nucleus of thalamus. I want to look at some videos on this to kind of put. Okay. The dorsal column, medial lemniscal, is discriminative. So the anterolateral spinal thalamic is non-discriminative. The dorsal column, medial lemniscal, is discriminative. We're talking about stereognosis, 2-point discrimination, precise localization, fine intensity gradations, high degree of spatial orientation relative to origin of stimulus. So the anterolateral is poor spatial orientation relative to origin of stimulus, and the dorsal column medial lemniscal is high degree of spatial orientation relative to origin of stimulus. Non-discriminative, poor spatial orientation. Discriminative, high degree of spatial orientation. So, the afferent fibers of the dorsal column medial lemniscal is large and rapidly conducting. The origin is skin, joints, tendons, specialized mechanical receptors. Projection from dorsal roots of spinal nerve ascend to medulla synapse with the dorsal column nuclei, cross to contralateral side, and ascend to the thalamus, then project to sensory cortex. So I really need I need some pictures to help me with that. I'll get to that. Table 3.3, terminology describing common sensory impairments. Aberognosis. Inability to recognize weight. Berognosis is recognition of weight. Aberognosis is inability to recognize weight. Alesthesia. Sensation experienced at the site remote to point of stimulation. Allodynia, pain produced by a non-noxious stimulation. Analgesia, complete loss of pain sensitivity. Astereognosis, inability to recognize the form and shape of objects by touch. Atopagnosia, inability to localize a sensation. Causalgia, painful burning sensations, usually along a distribution of a nerve. Dysesthesia, touch sensation experienced as pain. Algia, hyperalgia, decreased sensitivity to pain. Hyperalgia, increased sensitivity to pain. Hyperesthesia, increased sensitivity to sensory stimuli. Hypoesthesia, decreased sensitivity to sensory stimuli. Palanesthesia, loss or absence of sensibility to vibration. Paresthesia, abnormal sensations such as numbness, prickling, and tingling without apparent cause. Thalamic syndrome, vascular lesion of the thalamus resulting in sensory disturbances and partial or complete paralysis of one side of the body, associated with severe boring type pain. Sensory stimuli may produce an exaggerated, prolonged, or painful response. Thermoanalgia, inability to perceive heat. Thermoanesthesia, inability to perceive sensations of heat and cold. Thermohyperesthesia, increased sensitivity to temperature. Thermohypoesthesia, decreased temperature sensibility. Oh my gosh. Phygmnesia, loss of light touch sensibility. Wow. And there's the anterolateral spinal thalamic tract carrying pain and temperature. So we have pain and temperature receptors, lateral spinal thalamic tract, all the way up. It stays on that one side. It crosses over. So it looks like it starts pain and temperature receptors on one side, crosses over to the other side, and then goes all the way up to the brain. Like I said, I'm going to do a better video just on those two tracks. Dorsal column meniscal lemniscal tract. Dorsal column medial lemniscal tract carrying discriminative sensation such as kinesthesia and touch. Discriminative sensory receptors go up, then it crosses over to the other side, and then continues up. We're going to look at that a little deeper. Then the patient care, principles and techniques of patient care. Here's your initial pain assessment tool. I blew it up. Location, patient or nurse marks the drawing. Intensity and quality. Use patient's own words. Prick, ache, burn, throb, pull, sharp. Patients have difficulty describing their pain. I try not to lead them when I ask them to describe their pain. I give them a little bit of time to kind of come up with it themselves. And if they're unable to, then I throw a few words out there, but I try not to lead them. Onset, duration, variations, rhythms, manner of expressing pain. Is it verbal? Is it facial? Is it sounds like moaning and groaning? what relieves it, what increases it, the effects of pain on your activities of daily living, on your emotions, on your relationship with others, on your concentration, and then other comments. Pain descriptions and related structures. Type of pain: cramping, dull, aching is usually muscle. Sharp, shooting is usually a nerve root. Sharp, bright, lightning type is a nerve. Burning, pressure-like, stinging, aching, sympathetic nerve. Deep, nagging, dull, bone. Sharp, severe, intolerable, fracture. Throbbing, diffuse, vascular. Assessment of pain. In the initial assessment of pain, the clinician should determine and document the following elements: pain onset, pattern of pain. Does it, when you have pain, does it stay in one spot, or does it start in one spot and then move? The exact location of the pain. Results of a pain questionnaire. Whether the pain radiates or spreads to other parts of the body. Description of the pain, that is, when is it at its best and worst? Whether it's constant or intermittent. What makes it better? What makes it worse? What time of day is the pain better or worse? What work or social activity is affected by the pain? And to rate the pain from 1 to 10, with 1 being the least and 10 being the worst. Here's a pain distress scale: none, annoying, uncomfortable, dreadful, horrible, agonizing. It's a simple descriptive pain distress scale. And then you have your 1 to 10 numerical pain distress scale. No pain, distressing, unbearable. And then you have your visual analog scale, which is no distress, unbearable distress. Here is a thermometer pain rating scale. No pain to the pain is almost unbearable. And this is your pain rating scales for children. Numeric, photographic, and that's the end. So, like I said, I want to do a little bit more on the middle reading out of the physical rehab book, about these 2 tracks here. I know there's some really good videos on YouTube. The myofascial pain and fibromyalgia is pretty superficial and brief. The pain, I think we as PTAs have been doing that for a really long time. So I'd really want to kind of do another video just on the sensory spinal pathways. Let's see how long this is so far. 43 minutes. So let's go ahead and stop here. And then I will probably do a focused video just on, like I said, the middle part of this reading. And I will probably do that tomorrow, because if you can't tell, it's late. It's almost dark, almost past my bedtime. And look what I got in the mail today. My diploma. It's official. I'm a graduate doctor of physical therapy. I am. Sorry about my hair today. I just went to sleep with it wet, so it's looking a little bit crazy. But anyway, I'm signing off for tonight, and I will continue bright and early in the morning. Good night.